welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Hepatitis C Screening in the Emergency Department. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credit will only be awarded for 1 year for nurses, expiring on October 31st, 2017. I'm Renata Anderson, Hepatitis Coordinator for the Alabama Department of Public Health. And with me is Dr. Jim Galbraith, Associate Professor of Emergency Medicine at the University of Alabama at Birmingham. Welcome, Dr. Galbraith.
Thank you.
And thank you for being here with us today.
Of course.
Dr. Galbraith has presented information on HIV and hepatitis C with our department in the past, and we're happy that he's here today to do this webcast to share his information and what they're doing in the emergency department with hepatitis C, and so that we can share this information beyond Alabama. So thank you again, Dr. Galbraith.
Great, thank you. Well, I'm honored to be here this morning. I'm going to talk about our hepatitis C screening program that we implemented in the UAB Emergency Department in 2013. We've certainly evolved over the last 2 to 3 years, and we've faced many challenges. We're hoping that the successes we've seen in our program can lead to scalability of our hepatitis C testing and HIV testing in our emergency department to other emergency departments throughout the state. For this program, I'm going to be talking only about hepatitis C. I'm going to start briefly by discussing the background and rationale for hepatitis C testing in the emergency department. I'm going to talk about our findings from the front lines of testing in our emergency department and make some mention of others that have been performing screening nationwide. Questions that you might have are likely to be related to the challenges and lessons learned we've had from the ED, and I'm going to speak about that, and lastly close on the public health implications. So many of you are aware or knowledgeable about hepatitis C virus, so I don't want to spend too much time on that, but for background for those that are not, hepatitis C virus infection, what is it? It's a contagious infection caused by an RNA virus. How is it acquired or transmitted? It's commonly by direct contact from blood from an infected person to another. Prior to the 1990s, the spread was primarily via blood transfusions or organ transplantation, and certainly had spread through injection drug use. After the 1990s, when we were aware of what hepatitis C was and had testing for it, and were able to test the blood supply, we see the transmission primarily via needles and equipment used for injection drug use. Other routes that are less common include sexual contacts, vertical transmission, and sharing of personal items like razor blades or getting tattoos. The burden worldwide is large. About 150 million people are chronically infected with hepatitis C in the world, and currently about 350,000 die each year related to hepatitis C virus. In the United States, the number is 3.5 million Americans. That's approximately 1% of our population. And we see approximately 15,000 deaths annually related to hepatitis C. And again, that number likely is an underestimate, as only about 50% of patients that have hepatitis C are even aware of it at the time. So that data is based on death records. There are currently 2 distinct waves of hepatitis C in the United States. There's the baby boomer population, or persons born between 1945 and 1965, who account for about 75% of the infections in the United States. And then we have another quarter of the infections that are outside that birth cohort. Largely where we're seeing the biggest climb in hepatitis C today is among a growing number of younger injection drug users. Hepatitis C virus Certainly, it will lead to chronic infection in many. Acute symptoms from hepatitis C are rare, usually causes a short-term illness, usually febrile illness, rarely leads to any liver failure or liver damage, and many patients who develop acute hepatitis C infection seek care for it. Chronic hepatitis C is a sequela that occurs once that acute infection is not cleared by the body. And about 75 to 80% of individuals who have an acute hepatitis C illness or an exposure go on to develop chronic hepatitis C infection. So a decent number of individuals will clear the virus on their own. Once chronic hepatitis C infection is present, this can lead, will last one, a lifetime, and two, can lead to some serious liver problems. That includes cirrhosis, which is scarring of the liver. It's the leading cause of liver cancer in the United States, as well as the leading reason for a liver transplant, and it can also lead to death. Underestimated by many is the mortality or the number of deaths associated with hepatitis C in the United States. It's currently at an all-time high and exceeds the death rates attributable to 60 other infectious diseases, and that includes HIV and tuberculosis. In 2007, the mortality related to hepatitis C eclipsed that of HIV infection. So what's possible now? Well, the good news is we have great antiviral medications that can cure approximately 90% of persons with hepatitis C, thereby reducing their risk of death from liver cancer or cirrhosis. The challenge, though, is that this disease is silent. It's indolent. Many people don't know they have it. In fact, half of individuals in the United States that have hepatitis C infection are currently unaware of that infection. And we also lack the infrastructure for screening of those individuals to raise their awareness. There are a lot of resource constraints that we have currently at getting patients tested, but also into treatment prescribers for cure. So in 2012, knowing the new direct antiviral agents were soon to be released, which were able to, an all-oral regimen to cure hepatitis C infection, the CDC augmented their screening guidelines for hepatitis C. Previously recommended populations to be screened were injection drug users, recipients of clotting factors or solid organ transplants prior to 1987 or before 1992, hemodialysis patients, persons living with HIV infection, persons certainly with symptoms of liver disease, and children born to HCV-positive mothers. The challenge was identifying those individuals with those risks, and these, again, were lifetime risks. And so for providers, many times these questions weren't being asked, and for patients, many times they didn't know exactly the answers. Knowing that the prevalence of hepatitis C was highest amongst the baby boomer birth cohort, which is estimated to be a prevalence of about 3% in the United States, the CDC revised their guidelines to recommend screening, one-time screening for all baby boomers or persons born between 1945 and 1965.
And Dr. Galbraith,
Yes.
Looking at that list of risk factors, the number one question that I get from people born between 1945 and 1965, our baby boomers, is why should I be tested for hepatitis C? Because they're looking at most of those risk factors and they're thinking, I don't think I'm at risk, so why should I be tested?
Sure. What I would say, a lot of the risks and what we see in our baby boomers, even in the emergency department, is individuals who maybe they had a blood transfusion during an operation or when they had delivered a baby back in the 70s or the 80s. Many times patients are unaware of some of the risks that they have had, including those that could have been acquired, during medical procedures, for example. The testing itself is simple, and a one-time test, I think, is worthwhile for every baby boomer.
All right. Thank you.
Sure. One of the dilemmas we have is, where should we test for hepatitis C? Obviously, we should be testing in primary care. This is the ideal setting for any type of preventative care, and especially screening. The challenge is that oftentimes in the primary care setting, the prevalence or the number of individuals identified is a little bit lower than in other settings. Advantages to primary care in the ideal world is that you have a simpler process of referral. You're already established with your primary care physician. Your primary care provider can also identify and treat other contributing comorbidities. So hepatitis C may not be the only disease affecting an individual and shouldn't be the only priority. We need to manage patients with hypertension, diabetes, etc., and certainly those things need to happen as we're considering treatment for hepatitis C. Otherwise, the benefits of treating hepatitis C may be lost. Lastly, hepatitis C with the new medications can be treated in the primary care setting, and you're going to see this happen over the next decade where primary care providers will begin treating hepatitis C with these newer generations of medications. So primary care is obviously the best setting. However, secondary care, meaning emergency departments, inpatient settings, subspecialty clinics, often identify a greater proportion of persons infected, but there are many challenges associated with this. One is the cost of the testing, and I'll talk about this later when we get to challenges. There are obviously workflow issues and competing priorities that you have in a secondary care setting, like an emergency department. And lastly, from a secondary care setting, for example, an emergency department, the follow-up counseling for hepatitis C results, as well as the referral process, is challenging. So I'm going to talk about our UAB Emergency Department hepatitis C screening. First, for the emergency department, we are well positioned to heighten hepatitis C awareness. We're the front door to the health system. We're the safety net. We're open 24/7, and our motto is anyone, anywhere, anytime. We've been a critical component to the public health infrastructure in the United States. We see over 140 million visits per year. At least half of our population visits the emergency department one time per year, and we have a high volume of simply unique visitors. We also have a track record of experience and success with other public health interventions in the emergency department.
Now, Dr. Albert, that is a staggering statistic. So at least half of the U.S. population enters the emergency department at least one time per year.
Correct.
And you say that you have some track record or experience with success for public health interventions in the emergency department?
I think there are numerous, but one of the greatest successes, especially in urban emergency departments, has been HIV screening. And I'll use our UAB emergency department as an example. Since 2011, we've been performing universal opt-out HIV screening in our ED, and we identify HIV infection in 1 out of every 200 unique individuals coming to our emergency department. That leads to a diagnosis about once every other day. With that said, the success of our program is in our linkage to care. So not only are we identifying patients with HIV infection, some we're identifying, we're re-diagnosing HIV infection, but we're able to provide follow-up care for all of these individuals, and we're able to get 90% of our newly diagnosed infections into care with a treatment prescriber within 30 days. And I think that number itself speaks volumes to the success that an emergency department can have.
It does.
So why, we mentioned HIV, but why HIV and hepatitis C? Why screen in the emergency department? Well, one of the things we know about the emergency department is that populations that tend to be disparate users of our emergency department services in the United States, which are the uninsured, Medicaid recipients, non-whites, and persons living below the U.S. poverty level, and I think that's one of the greatest users of the emergency department, are those living in poverty, are also known to be disproportionately affected with HIV and hepatitis C. And many of these individuals lack access to primary care preventative screening for HIV, hepatitis C, and certainly many other things. But that makes the emergency department well positioned to identify and raise awareness amongst these populations and be able to get them into care. What's been done in U.S. emergency departments? This is as of the end of 2015, but you can see that largely prior to 2015, much of the testing that had been done in U.S. emergency departments was blind seroprevalence studies, just identifying how much hepatitis C was present. And you were seeing prevalence rates ranging from 4% all the way up to 18%. In 2015, myself and Doug White, who's in Oakland both initiated targeted hepatitis C screening, and I'm going to talk about our program in a moment, but targeting baby boomers, injection drug users, newly diagnosed HIV-infected individuals, and patients with new symptoms of liver disease. And both of us identified previously unrecognized prevalences of 10 and 11.5%. So that was basically 1 out of every 10 individuals coming in getting tested, which is an alarming number. So how does our testing work? Well, our testing was built on the HIV testing infrastructure, and I'll tell you that our HIV testing works the same way as our hepatitis C testing, but they're 2 different offerings. We perform what we call integrated screening, and when I say integrated, I mean this testing is happening as part of the patient's routine care. This is not a separate process. We don't have a separate tester who does the counseling, does the actual testing procedure itself, and does the referral. We really share the burden of this testing process and linkage to care process amongst existing personnel in the ED, which is why it's been so successful, as well as why it's sustainable. The first step is the engagement of the individual for testing, and this happens at our triage desk when the patient first comes into the emergency department. Nurses are going to ask a large number of questions when a patient first arrives, especially as long as they're medically and surgically stable, and that's going to include information about the patient's chief complaint, why they're there. They're going to be obtaining vital signs, and they're going to ask some other questions. We have some routine screening questions about a home environment. We have some routine questions about suicidality and depression. And added onto those questions are questions about HIV and hepatitis C status awareness. And during that time, and I'll show a screenshot of our questionnaire in a moment, the nurse will perform an opt-out offering for the hepatitis C test for individuals who are unaware of their hepatitis C status. And based on the response of the patient, an order will be automated in our electronic health record for a test to be performed during the ED visit. Once that process happens, the rest of the cascade happens automatically. The hardest part is getting the test ordered. Once it's ordered, the testing is performed on venipuncture specimens acquired by the nurses during the emergency department stay. Once the patient arrives back in an emergency department bed, it's performed in our hospital laboratory on the Abbott Architect instrument. There are multiple instruments that can run hepatitis C testing. The instrument we're using gives us a result in approximately 30 minutes, which allows us in real time to be able to tell the patient their result while they're there for the emergency department visit. So that means the counseling, post-test counseling, is able to happen in the ED for the vast majority. I would say 95% of our patients receive, for our hepatitis C positive patients, receive counseling by the emergency department provider during their emergency department stay. And then after that emergency department stay, whether the patient is discharged to home or comes in as an inpatient, we have a referral process, and we have linkage to care coordinators, which includes personnel that have degrees in master's in public health and a master's in social work who are assisting us in making phone calls and getting patients into a hepatitis C treatment prescriber. And I'll talk about that more when we get to challenges. This is an older screenshot of our questionnaire. Many people ask, what do we ask of the patients? Initially, we simply asked, have you ever been tested for hepatitis C? And then what was the result of that test? And then we offer an opt-out statement. And our opt-out statement goes along the lines of this. We perform routine hepatitis C testing here. A test will be performed today unless you wish to decline. And what we find is that 85% of the eligible individuals who get that statement say, sounds good. And that goes for HIV as well as hepatitis C. We see no differences in the opt-out rates of 2 separate offerings for HIV or hepatitis C. We also have the opportunity for physicians to manually order a test for hepatitis C. The vast majority of our tests happen from the automated order at triage, but physicians can put in an order, but the only thing that we require in that order is they document an indication. And what that allows us to do is for reporting after the fact, I can go back and see, was this an automated order not based on any risks, or was this an order based on an individual who has a history of injection drug use? So that's why we have that requirement in place. Addition to this order, because we have seen a large number of individuals who state they have hepatitis C, and the process seems to stop there. And so we're beginning now to engage those individuals in their interest in being referred into care. And so we've added another indication, which is a rediagnosis. And the reason we run another test is to get a specimen for viral load confirmation. Many of those individuals have never been confirmed with hepatitis C. So we're able to get the viral load confirmation, which adds us a critical piece of information to get them in to care. So in 2013, we got a lot of attention when we released the results of our baby boomer screening in our emergency department. For baby boomers, we identified an overall prevalence of 11.6%. That's approximately 1 out of every 9 unique baby boomers coming to our emergency department was testing positive for hepatitis C. And most staggering was the vast majority of our patients that we were testing were Medicare and privately insured individuals, but the highest prevalence was amongst those that were uninsured or were Medicaid recipients, where we saw prevalence rates approaching 17%. One of the challenges with our targeted screening is that identifying the non-baby boomer targets, meaning the injection drug users, was challenging. What we found was 85% of the persons that we were testing were baby boomers or were older than baby boomers, and they had their test automated at the triage desk. The tests for injection drug use risks accounted for less than 5% of all test orders, which I believe was low. And we also found that there were errors done in the testing eligibility process. We had some incidental non-risk-based testing of persons that were born after 1965, where the nurse up front offered the test to maybe someone who was 30 years old when it was supposed to be for a baby boomer only. And out of 2,000 tests we performed in that younger group, we're identifying a 10% prevalence, which was alarming. And these were, again, these were without any risk indications. I'm going to talk about that more in a minute. One of the biggest challenges we have, though, is asking about some of the risks. So we're in the emergency department, and patients are coming in, maybe for a car accident, maybe for a common cold, or maybe they stumped their toe. But the providers are very uncomfortable about asking the injection drug use questions. One, it's hard to operationalize the asking of that question routinely. And two, we kind of fear that we're going to affect the rapport that we have with the patient. Like, what is the patient going to think when I ask that question when it may not be relevant to their reason for presentation? And for the patient, there's certainly a lot of recall bias. They have privacy concerns, and certainly they equally have concern about affecting their rapport with the provider who they're seeing for the first time in a very inconvenient environment. So these are some of the stigma, I think, is one of the large barriers that's preventing us from identifying that injection drug using population.
And so basically what's happening is that the provider is afraid to offend the patient. Correct. And the patient is afraid that they may even offend the provider.
Correct, certainly, absolutely. And for some patients, someone who maybe injects drugs or has a history of opioid addiction may be fearful that if they say this, the provider is going to undertreat their pain. So you can see there's a lot of conflicts regarding this question, and the patient doesn't really necessarily understand why we're asking. In fact, in many cases, if we know those risks, we're likely to do more. But it's a real challenge we face, but we've learned this lesson already, and it's with HIV. Mm-hmm. Instead of asking numerous stigmatizing questions, if the prevalence is high enough, let's make this test routine and offer it to everybody. Right. It's been cost-effective in HIV, and though that hasn't been proven with hepatitis C yet, because we haven't been going long enough, the answer is we're seeing prevalence rates of around 10%. I suspect it will be, and therefore offering to everybody without any risks in high prevalent settings probably is indicated. Mm-hmm. It's a good question. So that leads me to what we started in 2015. So in September of 2015, knowing that we have a growing epidemic of opiate addiction as well as heroin addiction, in Alabama, and particularly central Alabama, we revised our screening recommendations to be a universal offering. We wanted to identify and be able to engage the populations infected with hepatitis C and not have to ask all of the questions about injection drug use up front. We'll deal with those things after we have the diagnosis. It's not perfect, but the idea was that we'd identify more individuals affected. So our eligibility were essentially all patients born after 1944 to encompass that baby boomer birth cohort, and any individuals over the age of 18 and over, I should say, that were medically stable for an HCV questionnaire, which is the nursing questionnaire done at triage. The patient had to self-report no prior history of an HCV diagnosis and have no prior test result in our electronic health record. And all of this can be automated by the electronic health record. So basically, the electronic health record now identifies the patients in those age ranges and presents the nurse with two questions. Have you been diagnosed with hepatitis C previously? If no, we offer the test, and the electronic health record goes back and sees if we have a test result previously. What we found was these were our screening rates for hepatitis C testing going up until September 15, 2015. You can see that we were kind of fading down to about 20 tests per day. And immediately upon going to universal testing, we began testing between 70 and 80 individuals a day for hepatitis C. So our daily screening rates jumped. And what I will tell you is with the way it's operationalized now, this trend has remained stable, and we have not needed to do any new maintenance on our program to get screening rates up. Today, we're still screening 70 to 80 individuals a day. The other thing that happened compared to our targeted screening is in pink here, is that younger cohort born after 1965, we saw a dramatic rise in the number of tests performed. So where they were accounting for about 15% of all tests, we're now seeing the younger cohort accounting for up to 65% of our tests. And this was one of the more startling outcomes. So this is data on unique individuals tested in our emergency department during the first 5 months, going through March of 2016. We tested nearly 6,000 unique individuals. We identified 458 individuals that tested hepatitis C antibody positive. That was 7.7%, or right at 8% of the emergency department population coming in. For baby boomers, we didn't see a significant difference in the prevalence we were identifying compared to when we were doing targeted screening, which is what we would expect. We were identifying right at 11% testing positive. But for persons born after 1965, this younger than baby boomer birth cohort, we're identifying a prevalence of 6%, which is very high.
And was that group born after 1965? Those risk factors were injection drug use?
So that's one thing. We don't have those risk factors, so we haven't been asking the questions. What we know about the epidemiology of hepatitis C, though, is in this younger cohort, especially those persons born under the age of 30, the vast majority of these would have been acquired from needle sharing, from injection drug use. Can't say all of it, but our anecdotal experience in the emergency department is injection drug use is the primary risk factor. Okay. And I think this data will help put that into perspective too. Where have we seen the largest rise in injection drug use in the United States and in Alabama? It's in our younger white population, particularly younger, 30 years of age and younger. We're seeing it rise, especially in some of the rural communities. And again, let's look at the racial prevalence for the baby boomers and the younger birth cohort. There's really no statistically significant difference amongst the baby boomers in prevalence between black and white. African Americans were 11.8% prevalence, whereas Caucasians were 9.5%. But look at this younger cohort, and all of a sudden it becomes much more obvious. The Caucasian prevalence is approaching 12%. That's 1 out of every 8 younger cohort, white individuals coming to the emergency department testing positive for hepatitis C, and compare that to the African American population where it's 1 out of every 50.
Right.
So, and this right here fits with what we would expect to see related to the current heroin epidemic.
Across the country.
That's right. So we have really essentially 2 waves of hepatitis C. We have the baby boomer birth cohort, And then we have this younger group by birth year that is where we're seeing hepatitis C climb. This figure shows that. This is the racial prevalence by birth year, and you can see the staggeringly high prevalence amongst this younger white population, especially those persons born between 1975 and 1984.
Well, I'm just curious, since we're talking a little bit also about the heroin epidemic and injection drug use, when you do have these younger folks come into the emergency department, what have you seen? Have you seen patients come in high on heroin, or is
Sure.
there an increase of that?
Sure. I couldn't give exact numbers for it. What I can tell you, and I'm going to speak to this at the end of the presentation, emergency department presentations, certainly we're seeing an increase in the number of overdoses. We know just in Alabama alone that we've seen significant rises in the number of overdoses and deaths related to overdoses over the last decade. We're in Jefferson County alone, where I practice in Birmingham. In the first half of the year, we had over 100 fatal overdoses. That was in the first half of the year, and largely this was secondary to heroin, but increasingly secondary to fentanyl. We're seeing those effects in the emergency department every single day. We're also seeing the effects of soft tissue infections, heart valve infections. We're certainly seeing the effect when we look at hepatitis C rates. We haven't seen an impact on our HIV prevalence related to injection drug use, and I say yet, and we'll talk about that more towards the end. We're also seeing a large number of desperate individuals who are just wanting help, and they have nowhere else to go, and they're coming to our emergency department. But the truth is that some of these individuals, it's very obvious when somebody reaches what I say is the terminal stages of their opiate addiction. But that isn't the vast majority. And with hepatitis C screening, we're identifying individuals that it wasn't suspected by the provider, and this is something new, and these are the people that we need to be also reaching out to. We're waiting too long to engage this population, and in some ways, though it wasn't intentional, we've seen some benefits with our hepatitis C screening where we're able to identify some of these individuals that we wouldn't have expected previously. We think about injection drug use as being predominantly male and predominantly amongst those of lower socioeconomic status, and the truth is that though that is still true throughout the United States, the greatest rise we've seen is amongst females, amongst those with private insurance, and amongst those with higher income. This is affecting everybody. So hepatitis C has helped us in some ways and really bring to light how bad this problem is. And additionally, I'll tell you later, it's helped us to identify where the problem is the greatest in Alabama.
Okay.
That's a good question. So challenges, this is where we probably will have a lot of questions. And the challenges are to be expected. We're the emergency department, so we have a lot of time constraints. You know, our goal is to get people in, treat their emergent conditions, and get them out. Now, we'll say this. At UAB, we're a safety net hospital, and we recognize there may not be anywhere else for individuals to go, and so sometimes we do a little bit more. That's why we do our HIV screening in our department, and we have advantages being in an urban academic center where we have some additional staffing and resources available to us. But we still suffer probably greater than anybody in the state in emergency department crowding. We have wait times that are long. We are trying to get patients out of beds and into their inpatient bed, and new patients from the waiting room into their bed. And if you were a patient in our waiting room, you would want us to be doing that. With that said, it becomes challenging to integrate these little tests, and every time you do another project or another screening project, the nurses and everybody will ask, what's the next one? Eventually, we're not going to be able to get through an entire visit with all the things we're trying to do. So we have to prioritize them, and certainly we've prioritized HIV and hepatitis C as being important. Privacy is a huge concern. In many emergency departments, it's a curtain, or you're sitting in a recliner, so privacy is a real challenge. And I tell people this, and they seem shocked that I have to say it, but we actually do see some emergencies in our emergency department. But what we know nationwide is 1 out of every 10 visits is truly emergent, meaning a motor vehicle accident, a stroke, a heart attack, where they need a provider at the bedside nearly on immediate arrival. And the vast majority of what we see is really urgent, and then we see an additional part where we're playing the role of a safety net for individuals that really don't have access to care and have nowhere else to go. Right. And we're also happy to serve those individuals too, but it is, time constraints are huge. And you add to this, now this data only goes up to 2008, but this is national ED visits, and you can see the trend. National emergency department visits are rising. They certainly are at UAB. And the total, those little ambulances on that are representing the total number of emergency departments. While we've had this rise, the total number of emergency departments is shrinking. So we're just seeing more patients. We're 24/7, but we don't have any more time. You know, we can't add 2 more hours to the day, you know, to get through this. So that means we have to see more patients per hour. And that puts a lot of strain on the providers and the health systems. Linkage to care is certainly always going to be one of your biggest challenges anytime you're doing a public health intervention. And this is where your success is determined as how effective were you at getting patients not only linked to care, but cured of the disease you're looking at. For hepatitis C, this is our first 18 months of data, so this isn't up to date today at 3 years. But the same holds true today as it did 18 months ago. Of patients that are tested for hepatitis C that are antibody positive, on 85% of the individuals, we're able to get a confirmatory viral load test while they're in the emergency department. Why is this important? Is that we have to confirm the infection. If we were testing 6 patients a year, this wouldn't be a big deal, and we get them back in and test them. But I'm showing you numbers here where we're identifying patients in the thousands. And so when you have 150 patients that haven't had a viral load confirmation performed, that's a lot of visits, and that's a lot of laboratory visits or return visits to the emergency department to just simply get a blood test performed. Those, we miss them, and it's a challenge in other emergency departments. The patient is gone, they're in an inpatient stay, or the order was placed and the nurse didn't get an adequate specimen, or it just simply wasn't performed. So it happens. Please. Yes.
Just a question as far as linkage to care. When you diagnose them with hepatitis and HIV at the same time, and you're talking about 2 different viral loads, the whole gamut.
Correct.
And so how difficult is it to identify both viral loads, and then once they take the medication or linked into care, how easy is it to get their viral loads down considering they're co-infected?
Sure. I can answer the first part of that question for sure. So one, surprisingly, we have not we've probably in the 3 years, we've had 3 or 4 individuals that have tested HIV and hepatitis C antibody positive. I will tell you this, when we talk about counseling in the emergency department, what I train our emergency providers to do is focus on HIV right now. This is the most important condition, because once you get linked into care for HIV, we can then take care of your hepatitis C, but HIV is going to be the priority. We certainly draw confirmatory tests for both, and it's up to that provider if they want to disclose both at the same time. Many of them do, but when we do counseling for HIV, it's a patient-per-patient decision on how we do it, who's in the room when we do it. And so I don't have one script for every single patient. And that's the number one reason I get called from the ED in the middle of the night, is based on results that were discrepant, they're not sure about, or they're not sure how to counsel or handle the situation. With that said, HIV is going to be the priority for linkage, and we're fortunate at UAB is where these patients are linked to care, which is the UAB 1917 clinic. They not only have a long track record of, they're national experts in the treatment of HIV infection, but they also treat HIV and hepatitis C co-infection, and they're now treating our patients with hepatitis C monoinfection. So we have kind of one linkage source, but I use the resources for the HIV linkage to care to navigate these patients in as quickly as possible. And our goal for HIV is have these patients seen within 2 business days. And hepatitis C we take care of downstream. Once we have that viral load performed, one of our challenges is just simply getting an appointment made for hepatitis C care. And by appointment made, I don't mean, hey, call and make an appointment. Like, we were able to confirm and see that an appointment was made with a hepatitis C treatment prescriber. And we lose about 50% of our patients right here. Some of them are waiting on primary care access so they can get the referral needed to get for Medicaid or their insurer to get into the treatment prescriber. Many are lost to callback, inadequate phone numbers, or we reach them once and can't reach them again. And certainly we have a large number of individuals. For baby boomers, it's about a third that have other competing comorbidities, like cancers that they're currently getting chemotherapy for is one common example, advanced heart failure. And so hepatitis C treatment is not a priority. And so they never achieve an appointment. Once we have the appointment made, we see 75% of our patients showing up for that appointment, which I think is encouraging, but we still have a long way to go. What I'll show you in a moment is that it takes so long to get that appointment because of the large volume of individuals we're diagnosing that I think a lot of these patients simply just forget about the appointment or they deprioritize it, especially when appointment's made and it's 3 months away. Other things come up. I've been working with a colleague in Oakland at Highland Hospital in Oakland, California. He's been doing the same hepatitis C testing and linkage to care from their ED. And we compiled our data to look at, throughout the cascade, where are patients falling off. What we found cumulatively together is that both of our sites, 82%, had a viral load performed from the emergency department. We identified 70% of those that were antibody positive to be chronically infected. In fact, both of our sites were 69% exactly were of the antibody positives confirmed to be RNA positive. We're able to arrange follow-up on 50% of those patients, so a really big fall off there. We were able to see follow-up attended on 61% of the patients that we arranged follow-up on. And where we really see one of our biggest drops is when they get to the follow-up, only 25% of the patients that made it to follow-up actually have treatment initiated. And of those that are treated, 80% achieve a sustained virologic response at 12 weeks, which is essentially a cure. So once we get them there and we get them on medicine, they're great. I'm not a treatment prescriber, but I will say, in fairness to the treatment prescribers, is that getting the treatment isn't only up to the treatment prescriber. It's also up to the patient's amenability to, of wanting the treatment once they arrive. Most do. But it's also some of the hurdles and barriers in getting insurance approval or charity care approval to get the medications in hand. And so, in fairness, during this short time frame that we looked at, many of those that have follow-up attended are going to have another year's follow-up where they're going to reevaluate, aggressive social work, and try to get the medicine. So it's not that the treatment prescribers don't want to prescribe the medicine. They're fighting extremely hard. The barrier is getting the medications in hand for these patients right now. It won't always be that way. Yes.
I was just wondering, as far as the medication, do you think you lose some patients because they don't want to, I guess the length of time it takes to cure them? Isn't it like 6 months or so?
So it used to be 6 months. Now it's 12 weeks. And to be honest, I suspect over time the number of pills that they take and the duration of the regimen may be shortened to as little as 2 months. So previously with interferon-based treatments, yes, that was exactly the response. But now we have all oral regimen of medications. They're very similar medicines to some of the HIV medicines patients take, and they're highly effective. And they're highly effective now, not just for certain genotypes of hepatitis C, but there's new ones coming to market that are effective for all genotypes of hepatitis C with very low side effect profiles. Right now, the costs are just prohibitive. And so, but that doesn't mean we don't fight. So we're still fighting, and that's a large reason why I'm here presenting today and showing this data, is I don't see it as a failure on our part. I see it as a failure of our healthcare system. So part of showing this data is advocacy itself. But certainly I think some patients do get a little disenfranchised coming back for repeat visits and not getting what they want. Eventually you kind of stop showing up. I think we'll see the day in the next decade where the tides will turn on this and we'll have better access to these medicines. And at that point we can begin talking about eradication of hepatitis C from the United States, or particularly Alabama. For patients that do not have RNA performed in our department, it takes us about 100 days. This is our site and Oakland's site combined. It takes us on average 100 days to get an RNA test performed, and this just is showing you the challenges we have in getting patients back into care, to primary care, or back for a lab draw. It's really hard, and so it's real important that we get that confirmatory test during the incident visit. The time to follow-up attendance is lengthy. We've had waits over a year, but the mean time to follow-up is about 145 days. So lesson learned that we've seen with HIV infection is that length of time is too long and patients will fall out of care. We know that, and I believe the same is true for hepatitis C. So length of time to follow-up is too long. But again, unlike HIV, in 3 years, we've diagnosed over 2,500 individuals. So we're breaking the system. And the reason we're breaking the system is because the system and the infrastructure just wasn't prepared for this screening. It will catch up, and when it does catch up, we will be much more successful. Who could have predicted? The time to initiation of treatment is almost a year, 9 months, 271 days, so it takes a long time. If we get you started on medicines, it takes a long time to get there. So you have to have somebody highly motivated to keep coming back to get treated. We need to shorten that time frame. When we do that, we'll be much more successful. This is a confusing table. We've actually recently published this data, but these were negative predictors of linkage to care. Negative predictors were if you were male, certainly our largest negative predictor, meaning that you were not likely to get linked to care to a treatment prescriber. Number one was if you were uninsured. But our greatest predictors that you were going to make it, unfortunately, were number one, that you had cirrhosis and end-stage, a liver manifestation. So we identify you and you're in the hospital and you're sick and you have liver disease. We're certainly not going to let you fall through the cracks, but we're getting those patients in. But we're getting them in, they're obviously late. And the greatest predictor was having access to primary care. If you have a primary care physician, you had primary care visits during our screening process and our linkage to care process, we got you into care. That was number one. And I keep going back to that, is access to primary care is critical to be effective in linking patients to care for hepatitis C. That hasn't been true for HIV, but that's largely due to Ryan White funding, which doesn't exist for hepatitis C. Another big challenge that we need to bring evidence to consider revision is the reimbursement of hepatitis C screening tests. In 2014, the Centers for Medicare and Medicaid Service released a decision memo for screening of hepatitis C virus in adults. And this was largely secondary to the new CDC recommendation and a lot of inertia towards screening. And so they were making a decision, where are we going to cover hepatitis C screening? CMS will cover screening for HCV when ordered by the beneficiary's primary physician or practitioner within the context of a primary care setting. So we went back earlier and I talked to you about primary care versus secondary care. I can show you some of the results from primary care, and certainly screening needs to happen there. But the yield pales in comparison to many of the secondary care venues that are performing screening. Emergency departments, inpatient hospital settings are examples of settings not considered primary care. So essentially the statement has kept us from being reimbursed for our screening in the emergency department. These tests generally cost about $4. And I will tell you, that screening cost is minute compared to the cost of linkage to care, the monitoring of the program, et cetera. No insurance is going to cover that. But at a minimum, the screening costs, not being able to bill and get reimbursed for them, is a huge barrier. And we know today, we're now at UAB billing for HIV tests. We have a sustainable program, but this can't be sustained, and we can't move on or scale to other emergency rooms until we have more clarity on this decision. So lastly, we've got 10 minutes left. I'm going to talk about some of the public health interventions, and this is a public health audience, so I think this will resonate with all of you. So indications for emergency department universal testing, number one is the surveillance. We have tremendous surveillance potential in the data that we get from the emergency department. Well, again, we have a high volume of unique visitors. Second, we are well positioned to engage the opioid epidemic and persons who inject drugs. We have a wide geographic reach, including, and I'll show you this in a moment, but particularly our urban EDs, where we are seeing patients from all counties and zip codes around central Alabama coming to our emergency department. So that gives us data on a large population well outside of just Jefferson County alone. With hepatitis C, we have such a sizable yield. Again, we're talking about, overall 1 out of 12 emergency department visitors testing positive for hepatitis C, our yield is high enough that we're able to then identify high prevalent clusters. This probably you won't be able to see this well on your screens, but this was the geospatial analysis we performed. This was really only performed on baby boomers during the first 18 months of our screening program. But we actually tested individuals in over 65% of the zip codes in the state of Alabama. With that said, throughout central Alabama, we were able to highlight like statistically significant high prevalent clusters within communities surrounding Jefferson County. And we even saw some outlier zip codes within Jefferson County itself. I'll remind you that we have a growing second wave, and I've alluded to this numerous times, and this slide demonstrates it well, of persons who inject drugs in the United States. This is data from Massachusetts. That first figure on the left is the total number of cases of hepatitis C reported in 2002 by age. And you can see that it's all lumped together kind of amongst the baby boomer population. There's just one wave. Now let's look at the same data for 2009, and you begin to see two distinct waves of hepatitis C. One that is the baby boomers, and then further left you're beginning to see this growing wave that's in the younger population. What I'll tell you is that throughout the United States, this has been well studied, and including in the South, we've seen, this was reported in MMWR by a colleague named John Zibel. This was the increase in hepatitis C virus infections, acute hepatitis C infections in the Appalachian states, Kentucky, Tennessee, Virginia, and West Virginia. These were all individuals under the age of 30, disproportionately white, and you can see the climb in acute hepatitis C cases over the last decade. And I'll remind you, most are familiar with Scott County, Indiana. This happened just in 2015. Scott County, Indiana, a community of 4,200 individuals, they had an outbreak amongst injection drug users with 135 individuals infected with HIV. 96% of those that were interviewed reported injection drug use. So this was an injection drug using population. What people didn't recognize from that, as much because HIV got so much attention, was 85% of that population was confirmed with hepatitis C virus infection. That's confirmed. So that means they had viral load testing. So hepatitis C was there. HIV was on top of it. And my greatest concern is that some of the recipe for what's set up for an HIV outbreak in Scott County is sitting here in some of our communities in Alabama, and certainly is existing in Tennessee and other places in the South. It's a ticking time bomb, and I'm not trying to be an alarmist, but the recipe is there for this to happen, and so we need to be progressive about how we think about it. I think hepatitis C is going to be an important measure when we're screening to identify where potentially an HIV outbreak might happen amongst injection drug users. I'll remind you, Alabama, #1 in painkiller prescriptions per capita in the U.S. in 2012. What do we know about painkillers? Is that largely that is the gateway into heroin and illicit opiates. In 2013 and 2014, which is the latest data we had the #3 greatest rise in the United States in overdose deaths in Alabama. Jefferson County, I mentioned before, had over 100 overdose deaths in the first half of 2016. And I just spoke at a town hall in Tuscaloosa 2 days ago. And what I will tell you is that the problem with heroin injection and painkiller addiction is growing. It's alarming. And we really need better resources for this. We're underprepared right now, but I think it's got everybody's attention. So what are the benefits of emergency department screening? Well, I showed you that geospatial analysis performed earlier on our baby boomers, but what if we looked at it for this younger population? What parts of the map would light up? Now, this was done and not published, and it's not potentially representative of all of central Alabama, but just our emergency departments. But we've already been able to, based on a small number of individuals screened, begin to identify high prevalent cluster areas of hepatitis C amongst younger individuals. Again, I don't know that they all use injection drugs, but what I will tell you is that the surrounding areas there in red, those counties also, many of them lead the counties in Alabama in overdose deaths reported through the CDC Wonder database. So we're still investigating this now, but as we put pieces together, could surveillance done in emergency departments help us in targeting the communities that are the greatest affected? I actually believe it could. We just need a little bit more time. So I mentioned that earlier about identifying communities and clusters with a high prevalence of hepatitis C, particularly those where we're concerned about injection drug use. This data could help us to target community-level interventions. So now, a lot of big question that I get is, if we're going to start a community-level intervention for injection drug users, where do we go? Well, maybe we should go where we know there is, one, injection drug use, but two, where there's hepatitis C and where it's being spread. And so this helps us to target areas, and these are not the only areas. So I don't mean to leave a community out, because there are lots of communities in need. We just haven't seen patients in our emergency department from there. So I try to remind people of that. And lastly, hepatitis C, it's theoretically possible to eradicate this disease. We can make this an infection that we just don't see anymore in 20 to 30 years. We certainly need to treat baby boomers because we need to avert the ticking time bomb, which is the deaths and the morbidity and mortality. They don't have much time left for those infected to get treated, because it takes about 30 years to manifest the symptoms. But if we want to eradicate this disease, where we need to be targeting our intervention efforts is in those with injection drug use. And right now, as that's climbing, we're seeing hepatitis C rates climb, and we're well positioned, and we've got cure and enough knowledge to be able to potentially eradicate this disease if we really focus our attention on that population. I think that closes it out for me. So I'll open it up for questions or questions from you.
Do we have any email questions? Any questions by phone? Questions from the audience? We have one question from Dr. Landers.
Okay.
Thank you. I do have a question related to potential ACOG recommendations for universal screening of pregnant women. I know that many years ago, when we were able to have the opportunity to not only screen pregnant women, but we had something to offer in terms of treatment of the babies, a la hepatitis B vaccine at the time of delivery, along with HB. Are you aware of what ACOG might be considering in terms of universal screening, especially due to the about 5 or 6% overall risk of vertical transmission?
Right. I wish I was. I am not aware. What I will tell you is that this was not something that many of us also thought I didn't think I'd be considering this when I started emergency department testing, and some of the first phone calls I received were from our OBGYNs about these young women that were diagnosed in our emergency department were also diagnosed as pregnant. I personally believe that, depending on the setting, that we need to be testing for hepatitis C to avert the potential for that vertical transmission. Many times for an OBGYN, they serve as the primary care provider for many women in the United States, and this could become part of the routine practice. To be honest, I don't know the evidence well enough, but this certainly has the attention of the CDC and others, because this has been a repeat. Your question is one that I've received quite a bit, and I wish I knew the answer to it. I believe we should be considering, testing, universal offering for pregnant women, but I'm certainly not an expert in that venue. Sure.
Okay. Well, if that concludes, we have one more question.
I was just wondering, I know in HIV you can kind of gauge when the person, how long, if it's a short-term infection or a long-term infection. Is that the case with hepatitis?
It's not really. No. For many of our younger individuals, if somebody's 25 years old and they started injecting drugs when they're 19, we have an idea. Many times we don't. We're not diagnosing acute hepatitis C in our emergency department. In fact, our antibody tests would, in most cases, not pick that up. So we really don't have a good time frame. For someone, we get asked this question, especially from the baby boomers, like, when did I get this and how did I get this? And lots of questions. And you can go down through the risks, but for many of the baby boomers, most importantly is, we just need to get you treated. I always tell them, I can go down all these lists and we're not sure, but the bottom line is you have the infection and there's a cure, and let's move forward and let's get cured. So certainly these questions come up mostly due to stigma, and people are trying to figure out where to point the finger or point the blame. And the answer I give people is we're human.
Is the stigma as high with Hep C?
It's a good question. Is the stigma as high with Hep C as it is with HIV? I would say it's not. Much less difficulty during the counseling, and the response from patients is not the same from someone with hepatitis C as HIV, but certainly it's enough stigma to avert a test. Does that make sense? So it's enough to avert somebody from being tested, but not quite as strong as HIV. And our goal, and that's one of the reasons we kept the tests separate. I did not want the stigma from one disease to affect the other and make it like a bundled thing that if you get a hepatitis C test, you automatically get an HIV test or vice versa. And so we kept them separate. The truth of the matter is we see a 15% opt-out rate in both, and it's the same patients who say, I don't want either of those. And but stigma has not been a big barrier for us in getting our tests performed with our strategy. When you look at other centers performing opt-out testing, some have rates over 50%, some have rates over 80% of patients declining testing. It's all like how it's offered.
Well, thank you, Dr. Galbraith. We're at the top of the hour.
We don't want to go for another hour?
What do you think? No, we don't have another hour to go through. We're at the top of the hour, so this concludes our webcast. We want to thank you for bringing us all this wonderful information. We want to thank those who have participated in the webcast, and thank you, audience members, for participating. This webcast will be available on demand. Thank you again.
Thank you. Thanks for having me.